Hello, my name is Dr. Ronald Prane. I am an adjunct professor here at the University of Texas Health Science School of Dentistry in Houston. This is a lecture about the basics of oral appliance therapy for the treatment of obstructive sleep apnea and sleep disordered breathing. The basics of oral appliance therapy. This is my email address in case you need to contact me personally about any questions you have during this course, but there also will be a general email at the end for anybody who has any questions. I'm a professor here at the dental school, like I said. I also have a private practice limited to treating orofacial pain and sleep breathing disorders up in the Woodlands, Texas, just north of Houston. I'm boarded in both orofacial pain and dental sleep medicine. I'm also president-elect at this present time of the American Board of Dental Sleep Medicine. We do the testing for board certification. I'm also had the opportunity to publish in several journals about, mostly at this point, sleep disorder breathing issues. And I have no conflicts that would in any way taint my talk today. At any time during viewing, you can pause the computer if you need to read what's on the screen or for any other reason. At the completion, you will take a short exam which will complete the requirements for streaming video courses. You'll be told how to do that when we get to that point. This lecture, is going to provide you with basic understanding of oral appliance therapy so that you will be able to treat patients with sleep disordered breathing. The effectiveness of the therapy will determine the effectiveness of the treatment for the sleep disordered breathing. I want you to understand what the therapy involves. The therapy also involves using oral appliances, and we will go through some oral appliances, and I want you to understand how the oral appliances are able to treat sleep disordered breathing. I would like for you to be familiar with different types of oral appliances. I'm going to be viewing some in this lecture, but basically the foundation of oral appliance therapy is what I want you to know after going through this lecture and how it's able to treat sleep disordered breathing. Okay, you got all that? All right, let's roll. Let's start right at the beginning of the protocol of oral appliance therapy. There's two types of patients that are going to be presented for oral appliance therapy. The first one will be, the most common one, will be the patient who's never had a sleep study before. You do a history examination, you ask these screening questions, and you do an oral examination. And they have one of two things. Either they have signs and symptoms of sleep disturbances or obstructive sleep apnea, they have health concerns, blood pressure, cardiac. You do an examination, you can see that they're highly prone to possibly having obstructive sleep apnea. And the other way would be that they don't have any other signs of sleep disturbances, and the only thing they have is snoring. That's all they do is simple snoring, which is actually very rare, but it happens, okay? So which of these two categories these patients are in would determine what you do next. For the patient that has any other signs and symptoms of sleep disturbances, they are to be sent to a board-certified sleep physician, and they have to be evaluated by that sleep physician because only a physician can make a diagnosis of obstructive sleep apnea. See, OSA is a cardiovascular event, and it's a dynamic process that happens through the night. So the sleep physician will probably do a polysomnogram, a sleep study. Now, if the patient has no other symptoms, do a home unattended sleep study. It has to be a type 3, which is, there's 4 types, 1, 2, 3, 4. Type 4 is just pulse oximetry. Type 3 has 4 leads or more, and that's a more sophisticated home study, but you do it under the auspices of a sleep physician. Now, you've already talked to your sleep physician, and he's allowing you to do these studies, so you can send him your exam and the results. Either way, if they have evidence or not, it doesn't matter. It all goes to the sleep physician to make an evaluation. He will review it, he'll review your history, and then he will say, yes, send them to my lab, we need to do a full study, or he'll say, go ahead. It's okay to start a mandibular advancement splint. See, these are protocols that you set up with your sleep physician. I'll talk to him more about this at the end of this lecture. But this is one of the protocols out there. So you got the okay to do from the sleep physician. He gives you a prescription for oral appliance, and you make a mandibular advance and splint. Then as you do the mandibular advance and splint, you're advancing the jaw more forward, and you're titrating them. In other words, you're getting them to an optimal effectiveness of the appliance, and then you send them back to the physician for a final home study or a PSG. HST is home sleep study. And so that's the protocol for oral appliance therapy. Now, the other type of patient that comes into your office is one that you had already sent, or some other doctor has already sent them for a sleep study, or the physician has already diagnosed them with obstructive sleep apnea. They've already had that. They've already had a diagnosis. They come to you and say, hey doc, I'm on the CPAP, I hate it. There's another thing that you can help me out with here and get me off this thing. Well, you do your history and examination, fabricate the advancement splint, then after it's been titrated, send them back again to the physician for a final PSG. So that's the protocol for oral appliance therapy. Now before we get into appliances, there are some basic concepts you really need to understand and get under your belt. The one is obstructive sleep apnea versus upper airway resistance syndrome, which is kind of like a pre-apnea. It's important to know because which one of these the patient has will determine how you're going to titrate the appliance. So this is the way it works. When the airway starts to collapse, there is a reflex mechanism that signals to the brain, hey, your airway's collapsing. And remember, if you saw the other lecture, it's based on esophageal pressure. Pressure's dropping, the airway's collapsing, do something, and the brain says, okay, I'm going to put forth effort. And I'm going to clench to bring the tongue forward. I'm going to expand the chest at greater force. I'm going to toss, I'm going to turn. I'm going to protect this airway. And that effort cannot be done in deep sleep, so the patient has an arousal to the higher levels of sleep. That's through the activation of the sympathetic nervous system, if you remember. Those arousals are called respiratory effort related arousal. The arousal is caused because the patient is putting forth effort to protect the airway. Now, if this effort doesn't work, despite all this effort, the airway closes down, there's a drop in oxygen, in other words, the effort's not working, it's failing, that's the patient who has obstructive sleep apnea. Because now their blood oxygen's dropping down, their airway's closing down, they're stopping breathing. But if the effort works, the airway opens up, then they slide over into the other side there is called upper airway resistance syndrome. The effort causes the arousals, but the arousals cause what they call fragmented sleep. Their sleep is disturbed all night long by all this effort. They got all these events. The airway opens up because their effort's working. They don't have obstructive sleep apnea. They have upper airway resistance syndrome. Now there's no insurance code, ICD-10 code for upper airway resistance syndrome. It's just put under it's a subcategory of obstructive sleep apnea. But the symptoms are fatigue, they have TMJ problems, they have headaches, especially in the morning. They have other medical issues such as high blood pressure, blood sugar problems, drowsiness. We can now add cancer to this. T-cell mediated cancers is affected by disturbances in fragmented sleep and intermittent hypoxia. So that's the difference, because how we titrate our appliances, you can see that if the patient has upper airway, you're not going to be measuring their oxygen levels because their oxygen levels never went down. They don't have obstructive sleep apnea. Their problem is we need to stop the effort because the effort is causing all their symptoms. This is critical to understand as you enter into treatment of obstructive sleep apnea, because how we monitor the success of our therapy would depend on which way this patient is going. So now we have to decide what the therapy, and that all depends on the severity. Like I just said, maybe the patient's primary snoring. They don't have any other problems. They've done a sleep test, no problems, the airways with the oxygen drops and everything like that. They don't have any fatigue. All they do is snore. This is a very rare patient, but they do exist. Or the patient slides into upper airway resistance syndrome. There is starting to be some drops in pressure, and there is some effort to maintain the airway. And then they go into mild apnea, which is now the effort's not working, their blood oxygen starting to drop, and then they're going to moderate and severe. And so the type of treatment we decide to do on these patients would depend on where they are on this continuum. In order to do oral appliance therapy, it depends on working with a sleep physician. Wow, can you imagine that? A dentist working with a physician, just like the old days. Yes, you need to establish a relationship with a sleep physician in order to do oral appliance therapy. That's another whole lecture. But this is the physician's responsibility is this. One, they need to diagnose obstructive sleep apnea. They need to make the actual diagnosis. We should not be doing that. Even with auto-reporting of home studies and all that, we should not be making the diagnosis because they are going to be responsible now for this patient being treated. They are going to take the liability if this patient gets in a car crash or have a heart attack or something that OSA is causing. They're the one who is responsible for that. And then they are also responsible for number two, the final determination of the treatment efficacy. They're going to say this oral appliance is working, the patient's being treated, or they're going to say the oral appliance is not effectively treating this patient, we need to add a CPAP to him, or whatever it is, the physician. Sometimes they're effectively treated, but the patient still has fatigue. Back to the physician. Something else is causing fatigue. Maybe it's low blood iron, maybe it's low vitamin B, vitamin D, something, maybe it's an autoimmune disease, who knows? But that's the physician's responsibility to treat. We do not want to be treating that. We want them to say that our oral appliance is effectively treating the sleep disorder breathing. Our responsibility as a dentist is to determine if oral appliance therapy is effective for the airway patency, not if the obstructive sleep apnea is resolved or not. Our job is to make sure the airway is open. We do this with objective testing and subjective questionnaires. I'll get to that in a minute. Then our responsibility is to communicate with the physician as to how the therapy is going and when we're finished with it. And I suggest you write out what they call an SOP, standard operating procedure. I got this idea from a sleep physician, Dr. Swick, so we made one out and we both signed it. And here's some ideas of what to put into your standard operating procedure and get it in writing, and so when you go talk to the sleep physician, you've got this in writing and he can read it and make adjustments to it however he feels comfortable, and now you've established a good working relationship. You want to have in there the diagnosis by the physician, and he is to refer you for oral appliance therapy. That's in there. He's going to sign that. So yes, I'll refer you now. You're going to put in what your follow-up visits are going to be like. What's your protocol for your titration? Are you going to use HSTs, pulse oximeters? Are you just going to use questionnaires? Then you're going to send these to the physician. And then you're going to send them back to the physician. And he's going to make the final determination. That's the standard operating procedure. Then you also want to make sure you write in there, you both are making notes in your charts and your records. So I suggest you put this in writing, and you and your sleep physician sign this. And then there'll be no misunderstandings, and he will know what you're doing, and you will know what his responsibility is. So if you're in an area of Texas or anywhere else you're watching this from, and there is no local boarded sleep physician, then what you do, establish a relationship with any licensed physician. He will make the diagnosis then. But he will have to send the sleep studies either home or wherever he's getting them from. They have to be interpreted by a board sleep physician. That's the protocol for American Academy of Sleep Medicine. And so it may be in a remote area and he may send it to Dallas or Houston for a reading, but you're still working with a local licensed physician. So let's start with the diagnosis by a physician. He would use two things to determine the diagnosis. This is basic medicine here. One is subjective. Okay, Mrs. Jones, how do you feel? What are your symptoms? Oh, I'm tired, I can't stabilize my blood sugars, I'm starting to get type 2 diabetes, I'm trying all these things, I snore. Those are subjective symptoms. Number two, objective signs. Where do those come from? Well, those are the sleep testing. He's going to sleep test and he's going to see the oxygen drop, or he's going to see the effort. He's going to make a test designed to diagnose obstructive sleep apnea. Now, what he uses for subjective would be a sleep history, various questionnaires, Epworth, bed partner questionnaire, quality of life. Those are questionnaires you can get to. And what are the patient's chief sleep symptoms? We will use these too, because this is what we're going to track. When we titrate our appliances, we're going to be tracking their chief sleep complaints. Objecting, like I said, it's sleep testing by the physician, home monitoring, in lab. Whatever they decide to use, they can use it. They know the rules of testing and they know what needs to be done in order to facilitate the actual diagnosis. And then they will generate a report, and you will get the report, and this is what the report is going to look like. This is a sample one. In this diagnostic report, there are several things you need to look for, and I always circle every one I see so that we can then put them into the chart. You're going to get an AHI, apneic-hypotonic index, how many events they had during the night that the oxygen dropped. You're going to possibly see an RDI, depends on which scoring rule they use, 2007 or 2012. RDI is respiratory disturbance index, how many events they had that they had an arousal associated with trying to protect the airway. Then they should give you an ODI, that's the oxygen desaturation index. That's the blood oxygen. Now, remember what I just told you? If it's upper airway, that's going to be 0, because they're not going to have any drops in oxygen. But if they have an apnea, that will have a number there. It could be, I don't know, 10% of the night. They could have 15, 20, 30 events an hour. That's important to know, because if you're going to be titrating your appliance, that's the number we are going to be titrating, as you're going to see in a few minutes. And then they're always going to give you the PSO2. That's the oxygen nadir, or the lowest the oxygen went during the night. So these are all, now we take these are the objective testing that the patient had done. And we're going to put them into our chart, and we're going to track these things as well. So now you got the patient back, and the patient has several options. Maybe everything looks good. They just start to have issues when they go on their back. Well, then you might want to do positional therapy. In other words, get them into a device like a knapsack that prevent them from sleeping on their back. They may be just obese. You might want to get them into a weight loss program. Those are all behavior modification. Or maybe they have insomnia, and then you treat that. The medical treatment, number 2, would be CPAP. Those are the ones that physicians can do. We don't do CPAP. It's just a lot of another whole area of treatment that really physicians are very well equipped to do. Then look at number 3, that's us, oral appliance therapy. Number 4, combination therapy. You combine the two, and I'm going to talk about that at the end. You're doing oral appliance therapy and CPAP. Well, that involves us. And then there's surgery. What kind of surgery? Well, there's some UPPs, there's some tongue reductions and all that. That the only one that's really, really works, is very well validated, is orthognathic surgery. So the dentists are doing that too. So we're able to do 3, 4, 5 very well and effectively. Remember the basic problem? The tongue falls back and blocks the airway. Then there's a change in pressure, and there's an effort to make that go back to open, and if it's not working, then you slide into apnea. So the basic treatments for this, of all those therapies I just mentioned, options, the main ones are mandibular advancement splint or CPAP therapy. There's new alternative ones coming up, hypoglossal nerve stimulators, there's myofunctional therapy, there's different things that are out there now that are emerging we need to watch for, because we may need to augment them into our therapy. But these are the main 98% of treatment for sleep breathing issues are either CPAP or mandibular advancement splint. Basically, oral appliance therapy is using a mandibular advancement splint. And the efficacy of all of our oral appliances is based on the same principles as CPR. We're bringing the jaw forward, and as the jaw comes forward, the airway becomes more patent, more open. These studies here are in the references if you want to read about them. These have been around for quite a while. This is a patient, you can see the airflow, there's this jagged line, something's going on the top of the inspiration, and it drops down, and then the second line is esophageal pressure, which drops down to, in this particular chart, looks like it's down to 7 or maybe 5. Normal would be like 2 or 3. And then each time the pressure drops, the tongue is stimulated and activated. To what? To come forward, to stiffen up, to clench. That's the clenching. All right? So this is a patient has no mandibular protrusion, and this is what was recorded. Now they advance the mandible, look at how the airflow levels out, much more smoother. Look at the esophageal pressure, goes back to normal. And look at how relaxed the tongue is. Why? Because the airway's open now. The pressures are normal. The brain doesn't need to activate the tongue to open up the airway. So these next pictures are taken through endoscope that's up the nose, down the back of the throat, and you're looking down into the airway. And this was a study done by an anesthesiologist in Japan, and he put people in different positions just to see what the airway looks like. So the neutral position on the left there, you can see that it's open, small, but it's open. And then they advance the mandible straight forward, just straight forward. Okay? Look at how much it opens, it like doubles the size. And then you do the neck extension like you do in CPR, it opens up even more. But look what happens when the patient opened their mouth for these. It almost completely closed up. Now, there are some appliances that allow jaws to open, and they're okay to use. I think it depends on where the hyoid bone would be. If the hyoid bone is low, when the mouth opens, it's going to obstruct. But if it's a high-rise hyoid bone, that may not happen so much. This is to demonstrate the effectiveness of an oral appliance. The top line is the control. The numbers above those circles are the esophageal pressure, the pressure in the esophagus. So 20 will be 20 centimeter water pressure. That's positive pressure. But as the pressure drops down to 16, 12, 8, 4, you can see as the pressure drops, the airway starts to collapse more and more and more. And then you go into the negative pressure, right? Negative pressure would cause the airway to shut down completely because it's negative. Yes, it does. There it is. Now you put on a mandibular advancement splint, and your pressures are dropping, the airway is staying 100% stable. Even in the negative pressure, the airway is still open. So the airway can handle negative pressures because it's physically held open by the advancement of the mandible. So, what is the action of our oral appliances we use to treat sleep disorder breathing? Well, there's anatomical. Direct anatomical effect. And by the way, there's a lot of research on this. It's still coming. There's things that are happening we still don't understand, but this is where we are right now. The tongue comes forward because it's attached to the jaw. It's attached to the mandible. Bring the mandible forward, the tongue automatically comes with it. It brings the mandible forward, and it also lifts the hyoid bone when you bring the jaw forward. Then there's neuromuscular effects. There's an increase in baseline genioglossus muscle activity. There's a muscle tone, it stiffens up the muscle. Now this is important because when we get into combination therapy, this is how oral appliance therapy helps the CPAP, is by bringing the stiffening up the muscle actually. Now the anatomical effects, if you read the studies, it not only brings the airway open anterior posterior, but also laterally. Okay, now this is a CT taken by Dr. Thornton. It's actually his uncle that was in it. And the CT is showing how the patient is asleep. These are very fast slices, and they're also monitoring the oxygen. And you can see the respiration's getting deeper and deeper as the patient's going to sleep. And when he falls asleep, watch how his tongue falls back. You can see the airway there, it's pretty big. And now he's going to sleep, respirations are getting deeper, and now he's starting to fall asleep, and watch the tongue fall back and obstruct the airway. There it goes. Now, that's the airway. Look at how the Bernoulli effect. You see the drop in esophageal pressure and the airway collapses with each of his breathing. Now they're going to wake the patient up and put in a mandibular advancement splint. This one was a tap. Now it's going to repeat the study, and he's going to go to sleep pretty quick this time. So now he's got the tap in place. Now look at how the airway is maintained. It's not only anterior posterior, but also laterally it's much larger. This is at the velopharynx. This is where the obstructions usually are, and this is where the oral appliances are effective. Okay, so that's how oral appliances work. Now the patient has had their sleep study and they've come to you. The MD has already recommended CPAP or MAS, and now the patient's looking for options. Or possibly this is the patient that you sent for a sleep study and now they're coming back to you for oral appliance therapy. Now you need to consider all the treatments. They don't get that from the physician oftentimes. They will get, you need a CPAP, because that's something they will treat them with. They know how to treat CPAP and they know the patient's going to be treated when they do their CPAP. But the patients are looking for something else. And the decision has finally been made to do a mandibular advancement splint. You have helped the patient make this decision. So, oral appliance therapy. How does it actually work and how does it compare to CPAP? So before you consider a mandibular advancement splint as the first-line therapeutic option, you have to consider the severity of OSA. All the studies show that sleep appliances are most effective for mild to moderate obstructive sleep apnea. They are not very effective for severe. You have to make sure they have teeth to grab onto. You have to have at least 6 in each arch or good implants. They have to have good periodontal health. The TMJ must function within normal limits. In other words, they have to open to more than 40 millimeters with no pain. And by the way, they need to be able to protrude their jaw, at least 7 millimeters. Anterior overlap in their front teeth is desired and preferred because that will prevent some of the side effects from happening later. So, statistically good responders to oral appliance therapy usually have a neck size of less than 17 for females or 20 for males. They must be able to breathe through their nose. If they don't, that's not going to say you can't do it, it's just that that might be a challenge. They have to be less than 50% of the normal body weight. Females are really good responders. Males usually have more severe apnea anyways, and mild to moderate, and then a short lower face usually responds well to oral appliance therapy. Now these are the statistics that show they are poor responders. And again, it doesn't mean you don't do them. You don't use oral appliance, but just be aware that you may be challenged in your results. Class 3 occlusion, especially, these patients can usually not protrude their jaw very far. And so that's the challenge there. If they're really small maxilla, then that's going to be a challenge as well. Now these are the 3 basic types of oral appliances, then there's subgroups under them. First one is the tongue retain device, affectionately known as the TURD. Then the second type is the mandibular advancement splints, which is almost all the therapy these days. They could be adjustable or non-adjustable. And then you do combination oral appliance therapy and CPAP, which I'll talk about at the end. So you can see the mandibular advancement splint, the adjustable, is by far the greatest used appliance. This was done back in 2001, but I think it's pretty relevant today as well. Maybe the TRD is actually less than 7% now, maybe down to 3 or 4. So this is the tongue retain device. When would you ever use this? The patient puts it in their mouth and stick their tongue into it and suction holds it forward. Well, let's say the patient doesn't have teeth. This is actually a very good option for those patients. Let's say the patient has a jaw joint, an artificial jaw joint, and he cannot protrude his jaw. This would work. So there is an indication for this, but basically these are not that comfortable for patients, as you can see. Now the fixed mandibular advancement splint is something that can be used, but there is a definition of an oral appliance that has been published by the American Academy of Dental Sleep Medicine. I was on that commission, and the definition states that it has to be titratable, brought forward, and this does not fit the definition. But it's something people can use. This is an example. This is a boil and bite. Why would you ever use this? Well, maybe perhaps the sleep lab calls you and say, hey, I can't get this thing stabilized, could you help us out? This patient's not being, their jaw drops back and I can't get the CPAP to work. I've done this before, and you go up to the lab and you heat this up, put in the patient's mouth in slightly protruded position, bingo. Come back to my office and then we'll make an adjustable one. This is the monoblock, simple, inexpensive, it's good temporary. Let's say a patient's going to Germany tomorrow and you can't get an oral appliance made. Well, you can make this overnight or during the same day to give them something to use. Or perhaps they don't think this is ever going to work. You can use this for proof of concept. I might use this for a teenager just to see if this stops them from clenching. And then we'll go into an adjustable one later. Adjustable appliances, there are a couple of different types there. I mean, this is where the bulk of all the oral appliances are in the adjustable, because these actually fit the definition. The first ones I want to just touch bases on are temporaries, and my tap is one example of those. And these are like a boil and bite. You heat the tray up in hot water and you mold it to the teeth, and then the attachment is in the front is similar to a tap appliance, and you can bring the jaw forward with that. The patient can do it themselves. Again, this is for proof of concept. This is being used actually around the world as an appliance that can be used in third world countries, because this is a very inexpensive unit to purchase, and so it has a use in our office too. Let's say your appliance breaks and the patient brings it in. You have to send it to the lab for a week or two. What are they going to do? Well, make them one of these while you're getting the other one fixed. So there are probably around 60 or 70 oral appliances out there, all made by different companies. They are FDA approved, and they've been patented, and I'm just going to show you a couple examples here, but my advice to you is to look at them, find them online, and call them up, get some examples, samples, and just get about 3 or 4, not more than 5, appliances that you want to work with, because those are the ones that your staff is going to learn, those are the ones you're going to learn, and those are the ones that you're going to stock parts for. You just can't be doing 15, 20 different types of appliances. I always tell dentists, think of it as like precision attachment days. I had 2 or 3 precision attachments I use all the time. Same with these oral appliances. And they each are different in the way they act. How many ways can you bring a jaw forward? You can push them from the back like this. This little mechanism that you turn a screw, and every turn brings the lower forward a little bit. You can pull them forward from the front, or you can push them from the back along the midline. Those are only ways you can possibly advance the mandible. So each appliance does it one of those 3 ways. This is another one that pushes from the back, Somnodent. The screw mechanism back there pushes the block forward on the upper, and the lower has the wings. And When the jaw falls back, the wings will hit that block and it'll stop the jaw from going back. Now this appliance allows the jaw to open and close somewhat. And so they're not quite as effective as when they're actually held together. But TMJ patients like these because their jaw is not held in a position. TMJ patients are used to having their jaw moving at night and they fight it when it is held together. So I'll use this for TMJ patients, especially with short teeth, because these grip on teeth very well. Herps has been around since the beginning of appliances. I don't believe anyone really actually holds a patent on this one. But this can be used. Different labs now are putting this particular mechanism into different types of appliances. Basically, the bar on the side can adjust, and the more you adjust it and you bring it forward. The problem with this, these are bilaterally adjusted appliances, and same with the Somnomed before, and the one before that, the PM Positioner, is that sometimes the patients will turn the mechanism one way on one side and the other way on the other side, and the patient ends up going crooked. Because I have my patients actually adjust these themselves, but we monitor it. We have them come in increments. And so sometimes they'll come in and their midlines are off. So I make a score in the midline of these appliances and tell the patient to make sure the midlines are lined up as they adjust these. The new kid on the block is a Narval made by ResMed. It's made from a 3D printer. It's made out of nylon, which is really inert. Patients don't have much reactions from these. These have sidebars that snap in and out in different lengths. The shorter the bar, the more the jaw is protruded. My TMJ patients love these because there's not much in the mouth. They're very flexible, but they're still very strong, and the jaw is allowed to move. Now, I would not use these for somebody who's got moderate to severe OSA because these are not that effective. If I get to somebody needing more effectiveness, like for somebody with more severe apnea, I'll go into a tap. The tap is very well studied. Probably over 260 studies on the tap have been made, and it's a very effective appliance because it mimics CPR. Dr. Thornton invented this, and he took the principles from CPR and applied it to this device. The top has a hook, which is adjustable. Along a screw there you turn, and the bottom has a little recessed area for the hook to grab onto. It can be latched by the patient. They can have their teeth apart before they latch it to relax, and then they'll latch it when they want. Each of these appliances have a different vertical to them. They have different spacing between them. And this becomes part of the art of oral appliance therapy, is this vertical. There have been countless studies about what is the best vertical, and sometimes it just comes to experience. You start looking at different ways of dealing with the side effects and complications, and one of the things you do is change the vertical. Basically, the basic concept is that the larger the tongue the patient has, the more space you want between the devices, the more vertical you want. If the patient is a TMJ patient, you want as small vertical as you can get. And airway management, Dr. Thornton invented Dream Tap. Because if you look at the tap, the mechanism's on top, and that's where the tongue wants to go at night. It wants to come forward and up to the palate. And some people did not like that mechanism on top, so he flipped it around and put the mechanism down below. That seems to solve that problem. This is a very popular appliance and it works very well. I use it as well. So basically, you don't want to use any appliances that is not FDA approved. It's quite a long process to get it FDA approved. But you see, you got to understand, these are actually breathing devices. These are class 2 medical devices like oxygen or wheelchairs. And so the FDA has to make sure that these devices are not causing harm on patients before they approve them. It's a lot of work. So the ones I mentioned and the other 65 that are out there are probably all FDA approved. Just don't use one that's not. That's my caution. So I'm going to talk about efficacy for a minute here. What the basic concept of oral appliance therapy with mandibular advancement splint is that the more you move the jaw forward, the more effective the appliance is to keeping the airway open and patent. This studies after studies after studies. It's basically protrusive dependent effect. It's a one-to-one, okay? The efficacy of the therapy is related to the degree of mandibular advancement. And while we're talking about efficacy, I just wanted to bring in a concept that was very well brought out by Sutherland in 2013. That's in the reference section here. This is an amazing study because it really brings out the difference between oral appliance therapy and CPAP therapy. There's two concepts to understand. Treatment efficacy. In other words, how effective is this device to intervene in the disease under ideal controlled circumstances? Not in the real world, just in the lab, measuring all the parameters, measuring the oxygen, measuring all the effectiveness of the devices. That is treatment efficacy. Treatment effectiveness is how well an intervention performs in an uncontrolled real-world condition. What does that mean? Well, CPAP is not well tolerated by a lot of people. It has a 50% acceptance rate out there. That means that 50% of people who get prescribed the CPAP don't even do it. And those that do, they only may wear it an average of 4 hours a night. So the treatment efficacy of CPAP is based on 4 hours a night or more. So when the treatment is usage as a portion of the total sleep time is considered, see, CPAP is more effective than oral appliance therapy. So CPAP has a higher efficacy than oral appliance therapy. And that's why doctors always tout it as the gold standard. Physicians say that's the gold standard. Well, yeah, it's very effective while you're using it, but the patient's only using it 4 hours a night. Oral appliance therapy has a higher effectiveness than CPAP. And the study showed when it comes to treating comorbidities such as high blood pressure and fatigue, oral appliance therapy is a higher effectiveness than CPAP because people wear oral appliances all night long. And so that's a great study to have to show physicians as you're talking about oral appliance therapy as being an effective therapy for their patients and yours. So what does an oral appliance do? As it brings your jaw forward, two things happen. The therapy becomes more effective, the airway's more open, more patent, it's working better, but number two, it also increases the risk of side effects. The more you bring the jaw forward, the more side effects patients have. Now this is another whole lecture that we are going to be having in this series on how to manage side effects. The most common side effects, of course, are tooth movement is the most common one. The other ones are usually transient, like TMJ and all that. That's transient, but you need to learn the side effects so you know how to manage them as the patient's bringing their jaw forward. We, as their treating practitioner, need to be able to deal with these side effects. That is why physicians should not be doing oral appliances, because they don't know how to deal with tooth movements. That's something that comes into our profession. So how do we measure the oral appliance? Now remember, we use the same parameters of measurement that the physician did when he first diagnosed the patient. Remember that? And we had the same thing that we're going to be tracking. There's an objective and subjective. Subjective symptoms we're measuring as the patient's coming in for appointments and we're titrating the appliance forward, forward, forward. And when we're measuring, we don't want to go too far forward. Remember? Because when you bring it too far forward, you have more side effects. So we want to minimize the side effects and maximize the effectiveness of the oral appliance. So we're looking at their subjective symptoms, one. We're tracking the original symptoms. Usually most common is fatigue. How are you sleeping? Is it restful? Daytime energy? And how do you know this stuff? we have questions. You can either ask questions or we have questionnaires, the Epworth Sleepiness Scale, or whatever you use at the beginning, you use during the titration. Number 2 is objective testing. How do we do that? We don't have a sleep lab here in our offices, right? But we can measure blood oxygen levels. Remember, that's for people who have blood desaturation to begin with. Those are the obstructive sleep apnea patients. Well, what about upper airway? Well, then I would look at their heart rate, because a pulse oximeter measures oxygen level and their heart rate. A calm heart will not be variable in its beats per minute. It'll hang around 60 to 65, 60 to 65. But when the patient has effort going on, what does effort do? Increases the sympathetic activity, right? So then you start, your heart rate responds to sympathetic activity as well. So it'll go from 65 up to 90, down to 40, and you're going to see on the graph, up and down high levels on the graph. That patient is producing effort to help maintain their airway, and you add that to the subjective findings, and you're going to say, we're not there yet. We need to advance more. But pulse oximetry also measures arousal events for those who do have drops in oxygen. And so I have 2 forms I use on every time I do a pulse oximeter. That's something that you will learn in a lecture about how to titrate these appliances. But basically, subjective, these are the 2 questions I ask: Epworth and global scale of impression. In other words, how do you feel about it? Things going well? Yeah, I love it. Or not so good. Okay. Then objective worksheet is I'm taking the original sleep study on the left side, and I'm doing a pulse oximetry or an HST on the right side there, and I'm able to compare them. And then on my worksheet, I talk about what decisions are going to be made. Is the patient, can they come forward anymore? No. Okay, so let's send them for combination therapy. Can they come forward? Yes. Let's bring them forward and take the test again. So that's how you titrate. You're constantly monitoring their objective and subjective, and when you've got them where you want them, what do you do next? That's right, you send them back to the physician with all this testing. He's going to be very impressed that you're monitoring these things, and send them back to a physician to make sure the obstructive sleep apnea is resolved. Now, there's morbidities. These are some of the side effects that I was talking about. You can get TMD, tooth movement, TMJ. The difference between that is the joint versus the muscles. You can get malocclusions, very common. But there's ways to offset that. And you offset that with different devices like the morning aligner and things like that. When you learn to work with these appliances, I suggest taking a workshop here at the dental school, and you can figure out how to work with this in your hands. Then there are minor morbidities. So let's say you're not able to make the oral appliance effective. Oh, I'm still tired, or oh, the jaw joint hurts, I can't bring my jaw forward anymore, and yet you still have oxygen desaturation. That's when you start thinking about combination therapy. What is combination therapy? Basically, it's a combination of 2 therapies. That's right. 1, CPAP therapy, and 2, oral appliance therapy. What are the indications for combination therapy? Well, first, you have the oral appliance therapy failure. If the oral appliance works, why would you add a CPAP to it? You don't need to. But if it fails, then you start thinking about doing combination therapy. But let's say the oral appliance doesn't work, but the CPAP does. Then the patient wears a CPAP. But if the CPAP fails, in other words, they're intolerant to it, they can't stand it, it makes it worse, then you start thinking about doing combination therapy. So you have to have failure of both these therapies in order to consider combination therapy. I did a study, just got accepted at the Journal of Dental Sleep Medicine. And I took my combination therapeutic patients and I did a survey, and I was looking at who got this therapy, what type of patient ended up going into combination therapy. And on the left, those are the monotherapy, oral appliance therapy failures. 11% of them ended up going into combination therapy. Those that did came from that. Then there's the combination therapy, which I'll talk about in a minute, of just the nasal pillows. That's 28%, but the bulk of the people that went into the custom mask, which is a device we use for combination therapy, a bulk of them are severe apneics. They could not tolerate the CPAP. And so they're severe. And my studies show that they are on the severe end of the spectrum of obstructive sleep apnea. So us as dentists are usually unable to treat these patients because on the severe end of the spectrum, oral appliance therapy is ineffective. And so we start thinking about combination therapy. So having the ability to do combination therapy is a great adjunct to your ability to treat the whole spectrum of obstructive sleep apnea. So there's two types of combination therapies. Type 1 is called dual therapy. In other words, we're combining the two therapies together. And this is something every dentist who can do oral appliances can do this type of combination therapy. You take a CPAP and you give the patient any oral device you want. It advances the mandible. So now you're augmenting the CPAP by stabilizing the mandible. This is the key. The problem why CPAP doesn't work most often is because the mask leaks, because the jaw is unstable. It moves around, it leaks, it drops back, and it obstructs the airway more, and the patient is struggling. And so if you want to build a bridge to a physician, just come over to their office and say, give me all your CPAP failures. Give me the ones that CPAP isn't working, it's the severe ones. I'll add an oral appliance to it and send them back to you, and then he will determine what the CPAP pressure should be and everything like that. So you don't have any other responsibility other than making the oral appliance, but you're doing combination therapy here. This type is called dual therapy. The other type of combination therapy, type 2, is integrated therapy. This is where you're integrating the CPAP and the oral appliance therapy. You're attaching the CPAP to the oral device. These are some samples of it here. This is something that has to be learned. You have to go take a course in this and learn how to make these custom masks or how to add on the pillows there. And basically what it is that inside the mouth there's two shells, upper and lower, and they're glued together, and a post is attached to that. So there's a post sticking out of the mouth, and on that post you can either put the nasal pillows or you can put the custom mask. The custom mask is taken from an impression of the face. You fabricate the shells first. Stage 2 would be that you would have the patient lay back and you take a face impression, and that's why you have to learn how to do this. And from the face impression, it gets sent to the lab, and then at the lab, they fabricate this custom mask. It's called a fusion custom mask. This was actually invented by Dr. Keith Thornton, but now it's called the fusion custom mask, and it's something that is used to treat the severe end of the spectrum. It's also a great marketing tool to show physicians that you're able to do this, because now you can really help them with their severe patients. So I want to thank you for your time here, and a couple things I want to mention here before we close. To learn how to do this from a lecture is one thing, but it also requires a workshop. Dentists are used to working with our hands. We are using our hands to develop these devices and fabricate them and to work with them. And so going to a workshop to actually learn how to do oral appliance therapy is absolutely critical if you're going to start doing it yourself. What I hope this lecture has done is to give you thought, is to give you pause before you jump into this, to say, there's a lot to this, I need to learn more. And it is an incredibly satisfying thing that you can do in your general practice, because you are saving people's lives, you're improving their quality of life, and you're also offering your patients a better, higher quality of service. So thank you again, and I hope again this spurs you on to do more and to learn more. So I wish you luck on the exam, but most of all, I hope this lecture inspires you to treat these disorders in your patients. I hope you start screening for them. I hope you learn how to do the exam. I hope you learn everything. The American Academy of Dental Sleep Medicine offers a lot of courses, as does the school here at UT Health in Houston. We are developing a lot of postgraduate courses in order to give you more education and ability to treat these patients. This is the email to send if you have any clarification on anything I said. And also my email at the beginning of the lecture is in there too, my own personal email. So this completes the course in Basics of Oral Appliance Therapy. Now it's time to take the exam. You need to get 80% on the exam in order to pass, in order to get qualified for requirements to have this as your CE. The other thing is that you will be able to take this 3 times. So you have 3 chances to fulfill the requirements here. The exam is not that difficult, and if you listen to this course, it'll be really actually very easy. This is my reference section. I have actually a lot of references in this talk, and these are the slides they pertain to. I'm not going to read through these, and you can pause and read them if you want. I'm very big on research. I think research validates. This is an emerging aspect of our profession, and the more research we do, the better we're validated. We don't want to be treating just because it works for other people. We don't want to try things. We want to make sure that these things work and their effect on the human body. And that's the way dentistry has always been, and I hope it continues to be. Thank you again.